be Dr. Lynn Caldwell. She's a senior research psychologist at the Naval Medical Research Unit in Dayton, Ohio, Wright-Patterson Air Force Base. And she has conducted research in fatigue countermeasures for over 20 years, first with Army Aviation, then with the Air Force. And I'm proudly presenting Dr. Lynn Caldwell, who's going to talk to you about fatigue countermeasures in aviation. Yeah, and the question, of course. And I'm forgetting about the question, so keep your clickers in your hand. And can we get Dr. Caldwell's question? I just forgot about that. Because we have quite an interesting question here. Sorry about that. That's okay. I don't want to do this. Just touch it. Can you get first the yes to go for? No, but I don't know exactly how it works. She gives it next sheet. Okay, the question is, should prescription or alertness aids be available to pilots who fly long missions? And you're already voting fiercely there. Maybe we should also see how fast you are reacting. Maybe that says something too. I think we're about there. So let's see what we get. Well, there you go.
Thank you. Here's my disclaimer, so you know this is me talking and not anyone else but me. Today I'm going to just tell you a little bit about something you already know, and it's already been shown during this week already, that we have a lot of information about fatigue in our services all through the countries, and so it's not a new topic. It hasn't been for many years, but it's very exciting to hear that people are beginning to use a lot of the information that's out there and applying that into their units. And that's, of course, the goal of every researcher, is to see that their work is being put out there into the communities as practice. So basically, I'm going to give you some information you already know just to review it a little bit, and then briefly go through some countermeasures, and then discuss some pharmaceutical and some uses of some of the pharmaceutical alertness enhancement aids out there. Of course, the definition of fatigue, when we talk about fatigue, we can mean a number of different things. And of course, when I talk about fatigue, my definition is long hours of wakefulness. It's basically interchangeable with sleepiness. And so whenever I'm talking about fatigue, I'm not mixing up that with people who have gone out and run 6 miles and they're physically fatigued, or if they have gotten into a vigilance task and they're now cognitively fatigued. So this is really using sleepiness instead of just the term fatigue to mean general tiredness. It's still a serious concern. Even though we are beginning to recognize that fatigue is out there, we're still having problems with accidents and incidences out there in our aviation community. And these are some statistics that you've probably seen with some of the things that you've been reading. They've also been shown a little bit here today, is that we're still having some fatigue in all of our services. We're having fatigue reported and as causal and contributing factors in many of our accidents out there. And it's costing us not only in aircraft, it's costing us in personnel, and it's costing us in just many of the other factors which are contributing to accidents. It's probably one of the least reported reasons for accidents, because it's very difficult to measure. It's probably one of the most underestimated reasons for an accident or an incident that we have out there. Of course, we all know what happens when we get sleepy, when we get too tired, when we haven't had enough sleep. And if you go down this list of performance and mental disabilities that are affected by being too sleepy, you can see that some of them are very subtle, and we may not be able to actually recognize those until they become very extreme. And so once we become extreme, then a lot of people can recognize that, hey, I need to either go take a nap, I need to get out from behind the controls, or there are many things that I need to do. It's when we're not quite there yet, when it's very difficult to recognize we're in those middle grounds of being well rested and being extremely fatigued. And so those are the types of people that we need to be able to recognize and be able to pull off from the cockpit, or to give a countermeasure so that they can either continue their mission or that they can go take a nap. The top 3 reasons why we have fatigue factors is, of course, loss of sleep, having a sleep debt. How long have you been awake? Sometimes we kind of put those 2 things together, but if we've been awake for 16 or more hours, then of course then we are beginning to have be under a sleep deprivation period. And sleep loss means maybe we had gotten a little bit of sleep, but we didn't get adequate sleep. And then of course we have the circadian factors, which go into that as well, which with our 24/7 operations, then we certainly have to deal with what's happening in those early morning hours of the night. So let's first look at factor 1, the acute and chronic sleep loss. We know that the average person needs 8 hours of sleep per 24-hour period, and most of us do not get that much sleep. So what is it that we can actually still perform well and still get by? Most of the sleep scientists out there say 5 hours. We're really pushing that up to 6 a little bit more now because we do know that people are chronically sleep deprived, and if they continue to get less than the amount of sleep that they need, then that accumulates over a period of time and they begins to affect performance after a few days. You can't train yourself to be better at sleep or to need less sleep. We do know that is a fact. And we do know that chronic sleep restriction is a very big problem that we can't really treat the way that we can treat acute sleep deprivation, the way most of the science has taken us up to this point. This is a graph from the folks down at Walter Reed, which just shows us that no matter how much we would like to think that we are doing really well with maybe 5 hours of sleep per night, if you can look at the graph, and the pink line up there is for people who are getting 3 hours of sleep per night. The light blue line are people with 5 hours of sleep per night. The yellow is 7, and then the green is 9. So you can see the first 3 days we've tested them on this test of just a vigilance test that, you know, how can you recognize when a signal comes across and press a button and do a reaction time? A simple, very short vigilance task. After you do that under a sleep restriction condition for about 3 or 4 days, you start to really see significant performance lapses. And if you look at the pink line, you can see that that begins to occur after about the second day of only 3 hours of sleep. The most important part that we learned from this particular study, however, was that we can't really recover very quickly from chronic sleep restriction paradigms. That if you look at those 3 days of recovery, where each of those people got 9 hours of sleep per night for 3 nights, they have still not recovered back down to their baseline performance. And that is where a lot of our research is taking us now. How long does it actually take us to recover from chronic sleep restriction? And that's a question that the research community is still trying to answer. We also know that that individuals perform differently based on their physiological makeup, their particular way of dealing with sleep deprivation. These are some data from some pilots that we put under 36 hours of sleep deprivation, put them into the simulator, had them fly different hours of the day for a 1-hour time period. And you can see that some people perform very well. This is change from baseline. And so at 2,300 hours, they had been awake for about, I would say, around 23, 24 hours, depending on when they went to bed, whether they went to bed at 10 or 11 o'clock the night before. Then as they progress throughout the day and were awake for the rest of the day, you can see that some people actually perform quite poorly, and they are really having a very difficult time. Some people did, or 1 or 2 people, did perform quite well under those deprivation conditions. And then, of course, there's the average where you're performing pretty poorly, but you're not really going down to like the people at the very bottom of this graph do. And that's again brought up some information that we need to pay attention to in our scientific community is what is happening to individuals. And Dr. Joe Chandler will be giving you some of that, some data that he's collected over the past couple of years on tomorrow, and we'll talk a little bit more about how the individual is affected by sleep deprivation. So then we look at not just how long have you been awake, but how long have you been awake over a continuous period of time. After after about 16 hours is when we start to see significant performance changes. And of course that also depends on when did that 16 hours awake occur and when are you testing that person, because we also need to take into account time of day. But this just goes to show us that a 12-hour work period is the absolute max that we can expect people to perform quite well, and actually that's stretching it pretty hard because of the prep time and the home time that people need. They're really going to have a hard time getting 6 or 7 hours of sleep per night on a 12-hour shift. And we've already seen the alcohol comparison with the time awake, and this is from the original study where that statements are coming from. If you look at how, if a person has been awake for about 24 hours, they are responding about the same as someone who is about an 0.08 alcohol concentration level. And then, of course, we need to look at circadian rhythms and how that is affecting our performance as well. We know that our sleepiness levels are at their highest on the early morning hours between 2 and 6. However, that it can go out a little bit later in the day because there are times when we've actually seen performance be at its lowest around 8 or 9 o'clock in the morning as well from someone who has had to stay up for the rest of the day and maybe on into the next day. So whenever we combine, or if you just look at the graph of what performance looks like at different times of the day, and this is very important for our 24/7 operations, we can see that most of the errors made occur during those early morning hours. You get a little bit of an increase in the afternoon slump. But this is why we need to really pay special attention to our night workers, or when we're asking people to do things even longer than what their normal bedtime is because we do get much more significant errors, much poorer performance in those early morning hours. So when we put those three fatigue factors together, then we're talking about a severely impaired person. So you combine the circadian rhythm, you combine that with the homeostatic drive for sleepiness when you stayed awake a long time, and you're going to get significant performance declines. So what are we going to do about that? And you've all seen a lot of the countermeasures which are available to you out there. Of course, the first countermeasure that you need is to get sufficient sleep. And of course, that's easier said than done in many, many cases. But if we can make sleep a priority, then we can get rid of a lot of the need for some of these other countermeasures. However, the mission and your work schedule and your lack of personnel may not be able, you may not be able to actually do that. So then we need to make sure that we implement some other types of countermeasures. We've seen a presentation earlier this week on how different schedules, making good shift schedules, can really make a difference in how much fatigue is in your shift workers. And they use the computerized scheduling tools. There are a number of them out there. The DoD is endorsing the fatigue avoidance scheduling tool, and so that's the one that you will see most if you look at DoD labs, but there are others out there if you want to pursue those. They're basically doing the same thing. They're looking at time since awake, time since last sleep period, time awake, and the circadian factors. Napping is a very good way to also help mitigate some of the short-term mitigation for fatigue. Breaks are a good idea as well. Sometimes if you just ask people to stand up rather than sit in a nice comfortable chair. When I used to teach at the Air Force Academy, I had many cadets that would stand in the back of the room because they knew that was a good way to stay awake and not get in trouble falling asleep at their desk. You can also make sure that whatever countermeasures people are using, that there's some science behind them. There are a lot of people out there giving you false claims. I had somebody tell me if you just chewed gum, you'd be just fine. Of course, they weren't talking about the caffeine gum. They were just talking about regular spearmint gum. And then education is very key. We heard from Dr. Bendrick how much he needed to make sure he educated not just the workers but his leadership as well, to make sure they understood, you know, what do you mean when you're talking fatigue countermeasures? What actually happens when you don't sleep well? So education is a big key. And then, of course, you can help people sleep at inopportune times with pharmaceuticals. And then, of course, the one that's the most controversial is to see should we give them alertness-enhancing medications out there. There are some safe medications out there with a lot of science behind them, and so that's what I'm going to spend most of my time on right now. The stimulants, which which we have out there. Most of them have been researched quite a bit. Caffeine, of course, we all know that caffeine is a very good stimulant when used judiciously. The problem with caffeine is that it is used quite frequently by people out there on a daily basis, and so we do get a tolerance to the effects of caffeine, and it begins to lose some of its effectiveness when you really need the caffeine. However, we do know that if you use it at the appropriate times, at the appropriate dosage, combine it with a nap possibly, then you can find that it will actually help improve performance in many situations. So this is a study which was done by the Brits, looking at driving incidences and showing that, if you take a dose of caffeine before you take a nap, then you take a nap about the time the caffeine kicks in. It takes about 30 minutes for caffeine's effects to get, and then you're waking up. And so the combination of having a little bit of sleep along with the caffeine will help you get through a little bit longer, maybe even for a couple of hours. This is a study that we did with the Air Force with the 117 pilots a few years ago. We had them stay up for 36 hours. During that time, we gave them 100 milligrams of modafinil, which was at the time not approved by Air Force pilots in most situations, in fighter pilots anyway. And we gave them dosages of 100 milligrams 3 different times during the day, and then kept them up for the rest of the day. So they were up for a total of 36 hours. And if you look at their mood scales, then of course with modafinil their moods were better. This is again difference from baseline, so we looked at a comparison for when we had them well rested compared to what they did when under dosages of modafinil. Their mood is better. Their theta activity, which is the slow waves that you expect to see when someone is asleep or into stage 1 sleep, then you can see that we have less of the theta activity after modafinil, and that their flight performance in the simulator is much better. It's still not at baseline levels, but it's certainly better than when we did not give them anything to help them through that 36 hours at all. Dexedrine, this is a U.S. Army helicopter pilots that we tested in this one. We kept them awake for 64 hours. At that time, that was a possibility. I don't know if that's still a possibility anymore, but when this was done, then it was very much of a possibility, at least for some of our people, that they were up for 2 or 3 days at a time with very, very little sleep. So these, we tested people with 10 milligram doses of dextroamphetamine across a 64-hour period, and as you can see that their simulator performance stayed fairly up there, pretty close to baseline, some of it a little bit better. There's a learning effect there as well. Compared to placebo. If you look at their theta activity, again, we get less theta activity with dexedrine than we do with placebo, and their mood states continue to stay fairly high. One of the misperceptions about dextroamphetamine is that people will get very hyperactive and that they will, do all sorts of crazy things. What we see with our pilots when we give them dextroamphetamine under these conditions is they become normal. So you look like you're talking with a normal person rather than somebody that's falling asleep while they're talking to you. Here was an in-flight dextroamphetamine study because we were told that, well, that's in the simulator. Pilots never fall asleep in the actual aircraft. We found that not to be true. They do fall asleep in the aircraft, and so when we repeated this study under 40 hours of sleep deprivation and gave them again 10 milligram doses of dextroamphetamine at 3 times during that time, then you can see that again their mood was fine, their theta activity was low, and their performance in the aircraft was better than it was without dextroamphetamine. So if you're not convinced by the graphs, there you go. Thank you. Then here is one of our 117 pilots after he'd been awake for 26 hours. This is the 9 o'clock flight. We just took a segment. This is a 2-minute segment of him flying in the simulator. The top is when he had no help at all. The bottom is under modafinil. It's the same time of the flight. This is a repeated measures design, so this is the same pilot. And my question to you is, which one do you think is going to respond better to an emergency situation or to something where he needs to be thinking clearly? And which of these pilots would you rather have flying your aircraft? And that's the question. Okay, thank you. All right, so now the question comes is, should we give pharmaceuticals, especially not necessarily over the counter, but should we allow our pilots to have access to those particular pharmaceuticals, whether it be a prescription, well, we're talking prescriptions right now. So there is no one-size-fits-all that's going to make a difference with them. And so we do have choices. We can choose caffeine, we can choose modafinil, we can choose dextroamphetamine. And so what we have to do is to weigh the cost and benefit analysis of determining whether it is appropriate to give a drug in these situations. And then if we say yes to that, then which drug do we decide to do? This is no different from you treating any other disorder that you decide, how am I going to treat this disorder? So, of course, we need to look at several considerations. The 4 that I have listed here are, what is the health status of that target population? Are they a healthy population? Would you give a stimulant to someone with a heart condition? You know, that's one of the questions that you may ask. How much medical oversight is this person going to be having? Is he somebody that's going to be looked at frequently by the flight surgeon, or is it someone who's going to see the flight surgeon maybe once a year? What are the side effect potentials out there? And then what are the consequences if this person does not get this medication and then they are out there doing their job and they fail? So there is always the cost, which you always do as flight surgeons, as docs. You always look at the risk versus the benefit, and you decide whether you give a medication, what is the likelihood if they do not receive this drug, what happens if they do receive that drug, and if they don't receive it, what happens if they have a problem, if they fail at their job. So in summary, we know that aircrew are fatigued. We know that we have mishaps which are due to fatigue, and those mishaps are underreported. It's very difficult to determine whether a mishap was fatigue-related or not. We do know that there are that things affect how well a person can make it through, how well they can perform under sleep deprivation conditions, and it doesn't matter how well motivated a person is, how professional they are. We can't train them to do better under sleep deprivation. They are still going to succumb to whatever their genetics tell them to do. And so should we give them some kind of fatigue countermeasure, and if so, what type of fatigue countermeasure should we give them? Should we pull that pharmaceutical off the choice, or should we continue to give them that choice? And somewhere I can go. And that was it. There we go. And if anyone has any questions, thank you for your attention. Yes, sir.
So my question, how do you screen your candidates concerning sleep apnea? And could you determine if they have a pathologic HII?
You mean in the studies, or in our studies, or in?
You have to check it before to include those kind of population.
In our studies, or in the pilot population in general?
In your study?
In my studies, we give them. Repeat the question. He's asking how do we screen out sleep disorders, basically, and we go through. We give them a full medical questionnaire, and we get their medical history. And then we also we do their EEGs. Since we were not a clinical lab, we could not diagnose. We're a research lab. We're not a diagnostic lab. So we just had to go off of their history and whether it had been caught by their flight physicals. Yes, sir.
But that's the problem we have. When in the normal situation, when we check our pilots, we can't use a questionnaire because they don't tell us the truth. What can we do in this situation?
I will leave that up to the flight surgeons out there who have that problem.
Were there questions in the questionnaire about the mental status, how they are satisfied with their life at all, the family life or the work?
We do not get into that. We were more looking at moods such as anger, sleepiness, concentration. We weren't looking at their psychological health.
Because in my opinion, there's always a cause why they don't sleep well the last time. That is the question. Why do they don't sleep well? It's not always because they have to stay awake all the time.
That's true, and that is exactly the decision that you would need to make when you're deciding, you know, does this pilot need to have a pharmaceutical for this mission or not? And, you know, there are many behavioral countermeasures that we can implement well before that we get to pharmaceuticals.
All right, and here's the woman with the clicker. Get your clickers, and please get the question that Dr. Caldwell asked us before, and let's see if anything changed there. Or you're already responding. I don't think I have to repeat the question. So let's see what happened. Paul, maybe you can come down for your message for the times with the buses. Oh, you have a slide? Oh, okay. I guess we're about there. I think we had about 90 responses before. So let's see. Did anything change? Ooh, nice. All right.